All right, good evening, everyone. Thank you so much for joining us. I'm Jennifer from the Adult Services Department at the Scotch Plains Public Library, and I'm very pleased to welcome our presenters for our program this evening. They are from the National Headache Foundation. The mission of the foundation is to create a future where everyone with headache can thrive. So they're here to share expert information and also to answer questions, although of course they cannot provide any personal medical information. Um, so we'll start the program with an introduction from Katie Oakley. She is the foundation's Associate VP for Strategic Partnerships and Programs.
Thank you so much, Jennifer. We're really excited to be here today. As Jennifer mentioned, I am the AVP of Strategic Partnerships and Programs, and I have been working with Jennifer to do exactly things like this, to bring programs to different communities, to help educate people about headache disorders and migraine disease. The National Headache Foundation, as Jennifer mentioned, we're a 55-year-old nonprofit organization, and we've been dedicated to bringing migraine and headache into the communities and helping people to understand that it is legitimate neurological diseases that significantly can impact people's lives. It's not just a headache. We understand that these diseases are still largely really misunderstood, underdiagnosed, undertreated. And so that is why we really want to help create a future where everybody who have headaches, headache attacks or migraine attacks can live optimal, functional, connected lives. As you probably saw in the event description, we're going to talk about overall what is a headache, what is a migraine, so you understand the difference. We're going to focus a lot on migraine, about symptoms, about red flags. If you do or don't have a diagnosis, what that path is to getting help and care and helping you to overall feel better and live a better life. Throughout the discussion, you are welcome to add comments in the chat or ask any questions. As Jennifer said, we can't give any medical advice though. And I am so thrilled to introduce Dr. Karen Williams. She brings over 40 years of experience in the healthcare field and specifically working with headache patients. She's retired from federal service. She was the deputy director of a headache center of excellence in Central Virginia at the VA there. Prior to that, she directed the headache clinic at Central Texas Veterans Healthcare System, and she treated service members and veterans at the Traumatic Brain Injury Program in Germany. She holds an added qualification in headache medicine, which is actually through the National Headache Foundation. She is certified with a 300-hour medical acupuncture program and is certified battlefield acupuncture instructor. She is a world of knowledge. We are so happy to have her a part of our community and to be able to present here today. So I will turn it over to Karen to give you all of the great information.
Thank you, Katie. Thank you so much for having us. I so appreciate this time. As Katie had mentioned, headache is very common. It can be very disruptive to your life. So hopefully we'll give you some information that will guide you and give you that needed boost that you have, or let you know you're on the right path, one of the two. So as we start out, we look at what are headache disorders, and there are many types. In fact, there are 150 different types of headache according to the international headache definitions. And so you may have more than one type. There may be one that requires more treatment than the other, but knowing that you have one type doesn't mean that's the only type you may have. We're going to talk primarily about primary headaches, which are commonly much more common. They do tend to run in families sometimes, with some portion of that being some genetics that play that. Now, unfortunately, they are chronic. They're not going to go away. They may reduce over time, but that doesn't mean that we don't have options as far as treating them. When I first started in neurology in 2000, we had limited options for that. And now there is a plethora of options for the treatment, both pharmaceutical and non-pharmaceutical treatments. So that is the important part. We'll talk briefly about some of those today. And ultimately, we do want you to know you're not alone. Don't suffer in silence with this. There are treatments, there's ways to get that help that you need. And there are many people that are in that path with you as well. Let's go to the next slide, please, Katie. So as I had mentioned, primary headache is the most common type. As you see there, it's 80 to 90% of the population. If they're going to have a headache, that's what they're going to have. And the idea behind a primary headache is that the headache is the problem. It occurs for no apparent reason other than that's part of your body makeup. There's no other cause. As you see with the secondary headaches down in that second row, those are linked to a specific cause, like a trauma, like post-traumatic headache or something with the neck or an infection or those types of things. Again, we're going to concentrate on migraine and go over real briefly episodic and chronic and what that means. But know that there are other types of primary headache. That's okay, Katie. Tension headache is the most common, but it's not one that takes you to the provider. So migraine, there is no diagnosis, there's no test that says, hey, I've got migraines, unfortunately. It is based on the characteristics of those headaches that you have. And so according to the International Classification of Headache, the migraine is characterized by at least two of the following there. So you see one-sided, so the pain is on one side and it's pulsating and throbbing. Now, it doesn't necessarily always have to be on the same side, and it doesn't necessarily always have to be one-sided, but that is part of the characteristic. One of the other main components is that the pain is moderate to severe in intensity. It really slows you down. You don't want to get up and start moving stuff versus a tension headache, which often when you get up, the pain is less. And with a migraine, it is also often aggravated by physical activity. So this means it's limiting your routine daily activity, whether that be work, school, or some sort of social activity. In addition to two of those, you need to have at least one of the others. And this is nausea and or vomiting or light and sound sensitivity. Now, usually the patients that I have seen have almost all of the above. But knowing characteristically wise, that is what that makes a migraine. Next slide, please. So a little bit more about it. As we had mentioned, migraines are very common and there's a genetic link to that. If you have a family member that has the migraines, there's a 40% chance if it's one parent and 75% if it's two. And unfortunately, often these are undiagnosed. And when they're undiagnosed, they tend to start getting worse, which increases the disability. So therefore, this is why we have these great programs that can help with helping you get that help that you need. Migraines are more common in women, and a lot of that has to do with the menstrual cycle. When children, it's about 1 in 11. But as women start with their menstrual cycle, that estrogen cycle tends to increase those migraines to the point where it's about 1 in 5 women and about 1 in 16 men. And the attacks tend to be more severe in women as well. The most prevalent ages, and this is more for women, is 35 to 55. Again, that is in the childbearing years. It's also where we're having those regular menstrual cycles. So it starts to level off and decrease after a woman goes through menopause. Sometimes during menopause, you can get that fluctuation that may increase it for a while. And as you can see, it can impact up to 1 in 4 households. It can be a major cause of disability and work loss, especially for patients who have chronic migraine. And it is the second leading contributor to years lived with disability. So it is extremely common and underdiagnosed. And again, that's why we have these programs. I mentioned episodic migraine versus chronic migraine. And the way they break that out is episodic migraine is less than 15 headache days per month over a 3-month period of time. Chronic migraines, you tend to have at least 15 headache days per month, of which at least 8 of those have features of a migraine. Now, again, the problem with chronic migraine is that it increases your disability ability to do your job, to be able to be at work or school. Also, often people that have chronic migraine aren't able to work full time, so they're less likely to have the health insurance they need, more likely to utilize the ER, and the last place you want to be with a migraine is the ER. You do not want those bright lights and that loud noise and all of that activity. You want quiet and dark. We do know patients can transition. So there is about a 2.5% chance of a person transitioning from episodic to chronic, but we can also transition back. And that's the other part that's good news. It may mean that you need different set of treatments, but again, getting it recognized first is the main goal. Go next one, please. So these are some of the sayings that we've heard from patients, but also things that both Katie and I have migraines, and different things that we have thought of as we have had a migraine. Sometimes people feel like others may say, oh, it's just a headache. So you see that when I'm not exaggerating, it's not just a headache, right? And we'll go into those symptoms that really show how much this affects the whole body. So it's not just in your head. You feel like you can't get out of bed. No one understands what I'm going through. All of these different thoughts. So you may have some of these thoughts or know somebody who does. And again, know that you're not alone with that. Next slide, please. So these are the symptoms and the contributing factors, some of them, not exactly all of them, but a good portion of them. And as you see the key down in the left-hand corner, you have the pound sign for the symptoms, you have the little star for contributing factors, and then you have a plus sign if it's both. Now, I want to go over a couple of these in particular. I'm not going to go over all of them in great detail, but when we look at the head and face, we talk about facial tenderness or sensitivity or pain or scalp tenderness. And sometimes people have so much tenderness that they can't even touch their scalp. They can't brush their hair. They can't have a ponytail in. They can't have a headband on. They can't wear a hat. I had a couple of patients that said the wind hurt. So that's a really good example of that your migraine has really progressed in getting extra help is really needed. One of the other things I want to bring up with that is facial tenderness. Sometimes migraines are misdiagnosed as sinus infections. A sinus headache can cause pain in that frontal area, but you usually have a green nasal discharge and maybe a fever, those types of things. I have seen patients get misdiagnosed even by ENT, telling them that they have yet another sinus infection, put them on yet another antibiotic when it's actually migraine. So getting the right diagnosis is important, and we'll get into the details of how you do that. A couple of other things I want to go over. When you see food cravings under the body, food cravings used to be thought of as a trigger for the migraine, but we now know is that is a preemptive symptom often that the migraine is coming. So it's something to consider and track as we're looking at all of the different symptoms that you may be having. When we look at vision, so what we're looking at often when we talk about vision is an aura, a visual aura that may give you those zigzag lines or the flashes of light or the shimmering stars or spots. Auras don't occur in everybody. They occur in about 25 to 30% of the population. They do not occur every time, but they can occur sometimes, and it can be quite alarming when it happens for the first time. I had an aura while I was working as a floor nurse years and years ago, and the first thing I noticed was I couldn't see out of part of my eye, and it got really scary, and then we finally realized over time that it was a migraine. You can also have some other sensory changes, definitely light sensitivity, sound sensitivity, and certain smells. If you are a person that is sensitive to smells, do not go near a store that sells candles or fragrant flowers or perfumes or cologne or around a smoking area, because those smells may trigger that as well. One of the other ones I want to bring up as well is barometric pressure change. We see that more in the spring and the fall, and it may be just that it's such a dramatic change, but those weather changes really can bring on the migraine. And then sinus and allergy issues, very commonly, people have that as a comorbid issue. Over on the far right side, when we look at sleep, mood, and activity, we do know the migraine brain thrives on consistency. So a change in any type of activity can increase that chance of a migraine. Irregular sleep patterns or having those stressors in life that are really causing you to feel uneasy or not being able to do your normal routine certainly can throw a wrench in all of that. And as we look down at the meals and hydration, definitely food sensitivities can be in there. Staying hydrated with water, trying to reduce caffeine and alcohol, staying away from tobacco products, those types of things. If you're a shift worker and you're not eating regularly, that also can be part of that. So trying to reduce some of those other factors can be helpful. Next slide, please. So this headache threshold is a thought process of how we are when we have migraine. So we always, in that jar, there's always a little bit of a level in there. And where cognitive behavioral therapy comes in, that is something that can help reduce some of the additional things that go into that jar, but we have to identify those first. So as you see this example, there was stress, and all of us have a little bit of stress, right? Unless you're a little tiny baby, you usually have some stress. You may have then had some poor sleep, or you may be expected to do much more than you had assumed for a certain job or those types of things. And then you had to skip a meal or some other life event that happened. And all of a sudden you get to that threshold and it overflows. Now you've got that migraine. So the idea behind this is to look at what are the factors in your lifestyle that we can moderate or change or take away and manage those skills so that we can empty that jar as much as possible. And it truly can be life-changing for some people when you start to really, it's a lot of homework looking at everything that you're doing in your life, but it can be so worth it. Next slide. So some of the common comorbidities for migraine, then there are a lot of them. It is pretty amazing that all of these kind of go along with migraine. Definitely depression and anxiety can be comorbid with that. I saw that a lot with the veterans with PTSD and anxiety as well. With either if they had a head injury or even without, you can still have that predisposition for migraines and then develop it after the PTSD, or it gets worse. Definitely sleep-wake disorders. If you have sleep apnea and it's not treated, getting it treated will probably reduce the number and the severity of migraines and also insomnia. So working with either mental health or working on ways to improve sleep habits are extremely helpful. Again, as I mentioned, the migraine brain likes consistency, so getting a good night's sleep every night is very helpful in reducing the migraines. Epilepsy, then asthma and allergies, and even chronic pain such as neck pain, back pain, and fibromyalgia. And then abdominal pain. Part of a migraine actually is the upset of the stomach and the nausea and the vomiting, so definitely all goes together. Now, I want to bring up one caveat. In a cardiovascular disease, there is an increased risk of stroke in migraineurs with aura. And that is important more with contraceptives in women. So if you are using a combined contraceptive of estrogen and progesterone, and you've had a history of migraine with aura, you really need to speak to your healthcare provider. It's probably not the safest contraceptive for you. There are other ones out there, but I would definitely not put somebody with aura on a contraceptive. Most of the organizations don't recommend that. This is a self-administered screener that Dr. Lipton came out with in 2003, and it's really helpful. Unfortunately, healthcare is so busy now. You go in and you may have 15 minutes with them. So it's nice to be able to bring in some extra facts. And this is something actually that the provider can have in their office to fill out as well, or you can fill it out at home and bring it in. And what the idea of this is, if you're having these three symptoms, so if you become sensitive to light, also known as photophobia, or does it interfere with the ability to function? Or do you feel nauseous or sick to your stomach? If you answer yes to 2 or 3 of those, then there's a very high likelihood that migraine is one of the diagnoses. Now, it doesn't rule out other ones. So don't just go in saying, I know this is exactly what I have and I need, know that you may still have other diagnoses, but this gives a good first look at, hey, you know what, there is really something here and I need some help with it. Next one, please. So there are red flags and there's reasons to contact your provider sooner rather than later. And there's one criteria that you need to go right to the emergency room. As you can see here, if you have persistent daily headaches that don't go away, if you're older than 50 and you start with a brand new headache, that is a red flag because that could be a different type of headache, or a child under 4 or under 5. If that headache never goes away, or if you have a weakened immune system, if you're having headache attacks that happen when you exert yourself, like you're coughing or sneezing or when you're changing position, it's another red flag. If there's fever, chills, sweating at night, and a new headache, or headache attacks that wake you up at night. If you're having a headache after a head injury, and a headache after a head injury is the most common symptom after a head injury. That doesn't mean that it won't go away, but it definitely needs to be looked at. As you can see, headaches with fever, rash, weight loss, neck stiffness, confusion, speaking problems, vision problems, weakness or dizziness. Those are all symptoms that need to be seen by the provider. And then if you are a person who has migraines or has a certain type of headache, but now you have an unusual headache, or it does not resolve with your usual treatments, that is another reason to be seen. If you have a sudden headache that's known as a thunderclap headache, so it becomes severe very quickly, takes you to the floor, that's an emergent care. You need to go to the ER for that, because that could mean that there is some sort of bleed in the head. Now, in my 25 years as a nurse practitioner in neurology, never did I have a patient come into my outpatient office and tell me, hey, last week I had this headache that took me to the floor. So I don't expect it's very common, but just know that, and I'm sure most people would be like, holy cow, I need to get to the ER. Just know for sure you need to. Next one. So headache calendars, tracking those headaches is really important. And there are a couple of apps you see there, the Migraine Monitor, Migraine Buddy. You can download those on your phone, or you can go to National Headache Foundation and download the headache diary there. Or you can use an old-fashioned calendar and write down what days you have headache and what days you don't. It's really important to track what days you don't have the headache, because you may only be tracking your severe headaches, but you may have other headaches that you don't even notice because the severe ones kind of throw you for a loop and then the milder ones are there. So it's really important to track what days are not, you don't have headaches as well, so that we can get an accurate feeling for what that treatment needs to be. Next slide. So what will that actual history and physical look like? If you could keep a headache history, that's really important. I always told my patients, I'm going to play detective. I'm going to ask you all of these questions. I need to know when these headaches started, where they occur in your head, how often you get them, how long they last, how severe are they, even if you can only tell me mild, moderate, or severe. Or for some patients, I would say green light, yellow light, red light. Are you able to do all your stuff? Yellow light, does it slow you down? Or red light, it's stopping you for the day. Describing the pain. Is it throbbing, pounding, light band, stabbing? Those types of things are important. If you're having other symptoms, are you having that dizziness that we sometimes can get with migraines? Are you having vision issues? Are you having speech issues? Are you having any type of other symptoms, nausea, all those other things? Is there an aura? And again, the most common is visual, as far as the visual, either the twinkling of the lights or the the blind spot, but you could get numbness down your arm or down your face as well. Those are some other auras. And how many types of headaches are you getting? And so that goes back to the headache calendar, trying to write what days are headache free. And then is there a family history? As we saw from the beginning, there's a genetic component to this. So it is helpful if there's a family history, then it can tie it a little bit better to what your diagnosis may be. As far as the physical exam is concerned, of course, they're going to do your blood pressure, your pulse, maybe your oxygen component. Doing a fundoscopic exam is really important. So looking in the back of the eye is really important to make sure there's no swelling of that optic nerve back there, because that can suggest that there's something else going on. If the provider is not able to do that, going to ophthalmology or optometry is another place that you can go and have that done. Looking at the head and neck, you want to do full range of motion of the head and neck, and also pushing on the different areas over the eyes, the TMJ area, the sinuses. The other area that I always recommend being pushed on or palpated is the back of the head here. So if you were to reach up to the back of your, the base of your skull and move from the midline over one thumb width, you'll find a little notch. That's called your greater occipital nerve right there. And then you move over another thumb width, you'll find another notch. That's your lesser occipital nerve. Those nerves give a sensation to the back of the head, and they can radiate that pain to behind the eye. I saw this all the time with my post-traumatic headache patients. And we can actually do injections back there to help that. But it's important to evaluate that if that's part of the plan that we need to do. Also, from a neurological standpoint, they should be assessing your speech. Are you consistent with it? Are you coherent? Are you able to change your tone? Those types of things. Looking at the cranial nerves, your reflexes, and then your walking and coordination. And then if there's any other things that they feel need to be evaluated. Next slide, please. So the pathways, the most common is the pathway up in the left-hand corner, pathway number 1. So that history and physical is normal. There's no red flags. It's the typical signs and symptoms of a migraine. So that's diagnosed. Then you sit down with them and you have that discussion as far as, well, this is my lifestyle, this is what I can and this is what I can't do. It's going to be an individual plan. Everybody should leave with some sort of acute treatment. That doesn't necessarily mean that it's a medication. It often is, and you probably started with an over-the-counter medication before you even saw them. But everybody should have something to abort that headache. Now, preventative-wise, there are a lot of us that do need a prevention, and it's more than just the ones that are having migraines all the time. It may be somebody who's having a migraine just once a month, but it's lasting 5 days, and they really need that medicine. Preventatives don't need to stay on lifelong, but they are something that you need for part of the time. Again, preventatives not only reduce the time of the migraine, but they help prevent you from going into chronic migraine. And then you would track and assess it. Now, path number 2, if they're seeing something abnormal, they may consider further testing, a CT scan of the head or an MRI, and certain labs. And you may still be diagnosed with a migraine and then going through those initial plans. And then pathway number 3, they're performing that physical and there's something very atypical and you need urgent evaluations. But again, pathway number 1 is the most common one. Next slide, please. So the stages of a migraine, this is something that came out probably about 10 years ago, and I found it so informative because it makes it much more than just the acute attack. We know the acute attack lasts anywhere from 4 to 72 hours if it's untreated. But if we move all the way back to that first stage, that interictal phase, so that's when it's time in between the attacks. And even then, you can still have that anxiety. You can be afraid of that next attack. This is where depression and anger can come in. So if somebody is having all of that, even if they're only having one migraine a month, a preventative may be really helpful for them. And then we go to that prodrome phase, which means your body's getting ready to have that migraine. And so when we talk about food cravings, this is when you may see that, but you may also see some of those other symptoms listed there. And again, tracking this can be really helpful because there are some medicines that they now find helpful to take in the prodrome phase. In that aura phase, it can last anywhere from 5 to 60 minutes. And as that aura fades, then the migraine, the true severe headache comes on. Again, the aura is in about 25 to 30% of the patients. And the most common is that visual disturbance, but you can still also have that numbness or the tingling down the arm, the speech difficulties, or the dizziness. The attack phase itself, we've gone through most of those symptoms already. It does not have to always be unilateral. For some people, it can be on both sides. And I would have patients tell me, usually it's on this side, and I know it's going to be okay. I'm just going to take this medicine. But when it comes to this side, oh my gosh, it's going to be a severe one. So again, tracking all of your signs and symptoms is really important in order to figure out what works best for you. Then there's also the post-drone phase where you still feel kind of wiped out, kind of hungover. And that's important to recognize that you still might have to take that easy. And then again, we go back to that interictal phase. So if you look at all of the time on this, 72 hours or 72 hours for prodrome, up to 72 hours for the migraine attack, and then up to 48 hours for the postdrome, we're talking a week. That's a long time. And so getting the help that you need, you really deserve that in order to reduce the extremities, the severity of that. Next one. So what do patients prefer for acute treatments? Well, of course, rapid freedom of symptoms is really important in getting back to normal function without having to take too many medications or repeated dosings. Ultimately, what you want is to know self-care, to reduce those resources as far as not having to go to the emergency room or going to office visits, those types of things. And then also reduction of adverse side effects. Some of those treatments can be worse than actual migraine. So we want to make sure we're giving you the right treatment without the added side effects. And then being able to afford it. Insurance, we've got to play games with that. In the VA, most of the treatments I'm going to talk about are available in the VA. But outside, it depends on what your insurance is. Next slide, please. So from an abortive or an acute phase, and these can be used in combination. So we've got our over-the-counter medications. Most people have already tried that. Then you have the combination, the over-the-counter combined medication that has the aspirin, acetaminophen, and caffeine. That can be extremely helpful. I do caution people, caffeine is in those combination tablets, and if you start taking that at night, it may interfere with your sleep. So then you're doubling down on having all that issue with the migraines. And then we have triptans, which have been around for at least 25 years. Those are very inexpensive and usually covered by insurance. The newer ones, dietans, and then the calcitonin gene-related peptide inhibitors, those can be extremely helpful. They are much more expensive, and hopefully insurance will cover those if the triptans aren't working. Anti-nausea medications can be extremely helpful as well. I've had a couple of patients that is the only thing they took when they got a migraine. If you are a person who's actually throwing up, consider a suppository, an anti-nausea suppository. It will work very quickly. It also will help make you sleepy, and sleep is restorative for a migraine. And then maybe being able to take another medication after that starts working. Now, I do want to just give a little plug. All of the over-the-counter meds, the triptan and the dietan, if you take too much of them, they can cause an overuse medication headache. So it is definitely something that taking more than 2 days per week for, if it's not working, then maybe considering a preventative. We do have neuromodulators now. There's about 5 of them on the market, and they do help with reducing the migraines and also often preventing the migraines by stimulating part of the nerves. I won't go into the detail on that this time. If anybody has a question on anyone in particular, I'll certainly be able to answer that after. And don't forget about lifestyle and environmental modifications. Being out in nature is extremely helpful, or having pictures of nature or a fish tank, or I in my office would have a picture frame that had pictures of nature on it. It's all very soothing for us and extremely helpful to get us to relax. Relaxation techniques are helpful, and so is thermal therapy. Often people like to use cold more than heat, but I had some patients that really liked heat as well. Maybe tinted glasses, especially if you're doing a lot of computer work, making sure you're turning the computer to nighttime all the time. Peppermint oil can be helpful to reduce the migraine pain, and ginger tea or ginger chews can be helpful. Don't discount soothing music or quiet. Those both can be helpful as well. So definitely many different things that you can do in your own life, in your own environment. Next one, please. Preventative medication. So when I first started, blood pressure meds, anti-seizure meds, antidepressants were about the only treatments we had. What I would try to do if a person has high blood pressure, I would try one of the blood pressure medicines on them first. So beta blockers and candesartan have both been shown to be helpful to reduce migraines. There are several different anti-seizure medications that have been shown to be helpful, topiramate and divalproic acid. I would not use either one of those in a woman of childbearing ages because both of them can cause deformities to the fetus. And topiramate in high doses will reduce the effectiveness of birth control pills. So I try to stay away from those, but for some patients, they can be helpful. Antidepressants, if there's anxiety or depression, that may be a good choice. We now have the CGRP inhibitors that are once a month treatments. Most of them are injections. There's one that is an infusion. And actually, there's one that is a acute treatment that also can be used as a preventative as well. Botulinum toxin, this first started with dermatologists, and then they found that, hey, you know what? People that were getting the botulinum for their wrinkles were having less migraines. And that's how that all started. Now there is a very standard format for injecting that. It's done every 12 weeks. It can be extremely helpful. Occipital blocks, I did talk about where those would go. Those are safe in pregnancy and can be very helpful to stop a migraine as it's starting, especially in a pregnant woman, because a lot of these other meds can't be used for them during pregnancy. Neuromodulations can also be used for prevention, and then we have vitamins like vitamin B2 and magnesium and CoQ10. Those have all been shown to be helpful. And then we also have mindfulness-based therapies, relaxation techniques, exercise, dietary modifications, so trying to reduce ultra-processed foods, also trying to stay away from some of the like MSG and some of the other ingredients that are in foods. And then again, talking about sleep hygiene, again, the migraine brain likes consistency. Next one. So goals for prevention, of course, number one is to reduce the frequency of the attacks and also reduce the overall cost of treatment, especially if you have to go in for multiple different appointments, and reducing that distress and the psychological symptoms. But also then to improve the response to acute treatment and avoiding that escalation and getting back to function quickly. And improving your health-related quality of life. So those are two of the main things we want to do. And ultimately, that leads to enabling you, empowering you, and successful self-management, because you may need multiple different types of treatments. And it's so helpful when you can figure out how to layer it. What works for you? Again, you are individual. And so what works for somebody else may not be the best plan for you or not work for you at this time in your life. Next slide, please. So just as kind of a wrapping up, self-advocacy is essential for success, especially in this day and age. The goal is to reduce the frequency, the duration, and the severity of those symptoms. And you do need to understand you are worth it, and you do need that accurate diagnosis. If you do not get the right diagnosis, then we are throwing darts in the dark. The diagnosis is most important, then comes the treatment. And you are worthy of reduction in frequency. Next one. You can go to the next one. So a dedicated appointment specifically for your headaches is highly recommended. You can start by tracking those headaches. Making that appointment, it may take a couple of months to get that appointment. Then start tracking your headaches and writing down your headache story, realizing that you may have to repeat this to different providers. So it's nice to have it written and having that headache calendar to document not only the days that are headache, but the days that are headache free. Next one, I think. So learning about those treatment options is really important, both pharmacologic and non-pharmacologic. Keeping open communication with your provider and care team. It is really discouraging when a patient comes in 2 months after I've started them on something and they say, oh, I stopped that 2 days ago, I didn't like it. So now we've wasted 2 months of time. And so please email or text or whatever, call whatever your provider has for the communication and say, hey, is this normal? Those types of things. Don't feel like you're bothering them. That you need to make sure the treatment's working for you. And then even if you feel like you shouldn't ask for a second opinion, if your treatment isn't working, then it may be the time after some time to say, hey, I'm going to go get a second opinion, or, just go get a second opinion. It's really helpful to do that. And with that, I'm going to turn it back over to Katie.
Thanks so much, Dr. Williams. I love hearing you present. I feel like it's so relatable and there's such helpful tips. Kicking it back over to National Headache Foundation, I mean, we just really want to make sure that everybody knows you're not alone. Headache disorders are real. Migraine disease is real. We have an insane amount of resources on headaches.org, which is our website. We also have a number of different patient programs. Operation Brainstorm is our program to help veterans and service members and their families. Dr. Williams has a series with us where we walk through that impact to the military community because of TBIs, PTSD, anxiety, depression, burn pits. The military community is impacted pretty significantly and oftentimes don't ask for help because they are built to be really strong and brave, and we want to make sure that they're getting the support that they need. Migraine University is our program that helps on the higher education side. So if you're a student navigating college or a graduate school program, we offer support on that higher side of the education spectrum. Everything from the transition from, if you have any children on the call, if you're their parent and navigating that difference to them managing their own healthcare, it's a really can be a really tough transition with things like sleep cycles changing, maybe alcohol entering the picture. All of those things can be really important to address so that students understand how it's impacting their lives. We also have an amazing podcast called Headwise, and it is the place to get all of the leading information in the migraine and headache community. We have a host who interviews experts in the field. We release almost an episode a week, which is, you can also find that on our social media channels. They're really wonderful. They're only oftentimes like 15 minutes. So it's really quick as you're commuting somewhere to listen to a topic. And then we have a number of other initiatives, everything from support in the workplace and helping to educate your employer to educating our primary care providers. We have a program on that. the certification that Dr. Williams has. We provide that to providers. And then we have a video series called Living with Migraine that is excellent. It's informational videos, very similar to this, that dig deeper into certain topics. If you would like to learn more, it's a wonderful series. And we now have some time for questions if anybody has any. Again, we can't offer any personal advice, but we are happy to answer any questions that you may have based on the topics we talked about. If nobody has any questions, I had one for Dr. Williams that I could pitch. The neuromodulation devices, I think that's something that not a lot of people know about. Can you just explain what it does, what it looks like, how you use it, just very brief, high level?
Sure. So, like I said, there's 5 different ones that are out there right now. There's one that fits right on the forehead, and it stimulates over the first branch of this nerve that's called our trigeminal nerve. You can use it for both prevention and for the acute therapy as well. That's been around for at least 5, 6 years and can be extremely helpful. I always want to try those on folks before I have them actually purchase it. That one is over the counter. There is another one that stimulates to the back of the head. It's a magnetic pulse to the back of the head that works very well. That is a prescription treatment, but it's like 1 or 2 pulses to the back of the head. There is another one that works to stimulate the vagus nerve, and it does a 2-minute stimulation here. It actually is also helpful for PTSD. They have found it to be helpful for that. There is another one that's an armband, and it stimulates the nerve on the arm. It does a peripheral stimulation, and you control the amount of stimulation with an app that you download on your phone. And I guess a lot of it's down to the age of 7 that they like using that now. That is for prevention, but also for acute. And there's another new one that came out that stimulates both over the trigeminal nerve and over the occipital nerves. So again, we're seeing this huge industry for all of these different ways to calm those nerve endings down. And it can be extremely helpful. In the VA, all of those are available, along with also another device that it's a thermal therapy device that does consistent cold or heat, and it has several different wraps that can be really helpful. So,
Thanks.
and I see that Karen had a question. Well, yeah, that's a great question. So Karen asked about caffeine. She's read caffeine is helpful, and it also can contribute to migraines. The prescription I take has caffeine in it. It is confusing, isn't it? It is a double-edged sword. So consistency is still helpful, and a little bit of caffeine may be helpful in a migraine, but if you take too much, it may go into that medication overuse headache. So those over-the-counter medications that are combined that have caffeine in them, if you're taking more than 2 twice a week, then you could go into that medication overuse. If you're taking your prescription medication that has caffeine in it and you're using it multiple times during the week, it can put you into that medication overuse. And what that headache feels like, it's more intense headache. It's a headache that doesn't go away. And unfortunately, what we tell people is stop the offending agent. Well, that may be what you think is help. And I've had patients for years say, no, this is what's keeping my headache away. I'm like, it's adding to the headache. So that's where a preventative can be really helpful as well, to reduce it back down so that it is working. The migraine brain is more sensitive. And, I have a mother-in-law who would drink coffee all day long and go to sleep at night. If I have more than 1 cup in the morning, I'm toast. I'm jittery and I don't feel good and all that other stuff. So definitely watching the caffeine intake from your sodas as well, and tea, those types of things. Sometimes the energy drinks, they're very bad for you. I don't recommend those for anybody. They all, just look at the caffeine content and monitor that. Did that help? She's writing another one. You can unmute if you want.
There I am. Hi.
There you go. Hi.
It's a lot easier than typing. So
Yes.
I am a tea drinker. Um, do you recommend maybe 2 cups in the morning and that's it for the day?
It really is independent. There's a lot of herbal teas out now.
Right. And I don't like herbal
You
tea.
don't like any of those. I
I've
like
tried.
herbal tea,
I've
but I put
tried.
in honey. I put in honey and milk in my herbal tea. So I
Yeah.
probably take away the effect of it. Um, if tea is the only thing you're drinking, there's not as
Right.
much caffeine in tea as there is in coffee.
Right.
And again, it's consistency. So in migraineurs, if they drink their cup of coffee at 7 o'clock in the morning during the week, but they sleep in on the weekend, they may wake up with a headache because they're not getting that caffeine. So getting that consistent time is really important. So it is individual as far as that. But if you're not getting a headache with the caffeine intake that you're taking now and your caffeinated prescription med works for you, it sounds like you're doing okay. But
All right.
did I help you?
Thank you. Yeah, I've read so many
I know.
conflicting stories. Don't drink caffeine. Caffeine helps. It's confusing.
Yes. And like if you're out and you're starting with a migraine, a cheater trick is to pop to anti-inflammatory or like Motrin or something like that in a soda with caffeine in it. It can really help. But that's not
That's
something
good.
you
Yeah.
should do all the time.
Right. Right. Okay. Thank you.
Uh-huh.
Any other questions?
I'm just curious about the phenomenon, I guess I would call it of ocular aura without a headache pain. Obviously, that's not nearly as disruptive a condition, but um, do you, can you talk about that at all?
Sure.
How those things can be dissociated?
Sure. So you can have an acephalic migraine. So you can have the symptoms, especially the aura, and we see that sometimes more in a person who has gone through menopause. So they may not get that severe headache anymore, but they're getting those visual changes. The first thing we want to do is make sure they're not having stroke symptoms or transient ischemic attack symptoms. So making sure that's worked up. Um, and I've had patients that have had that, they had migraines when they were younger, and now they were just getting the aura. We worked them up. They were not having any red flag symptoms. And we put them on magnesium and B2, and their symptoms went away. So you can still do the same preventatives for that, depending on how often you're getting it. But again, you need to make sure it's the aura from a migraine and not something else occurring. Mhm. Tell me if that didn't help, Jennifer, I'll explain further. So, okay, it did.
Okay.
Okay.
Any further questions?
Where can I get that T-shirt that I'm looking at? You're not alone.
This is so well timed. We're actually exploring creating an online store right now to purchase some of our items.
Okay.
So we also have a campaign, Strengthen Every Story. We've found that people feel so much less alone when they see and hear about other real people who live with the different type of, headache that they have. So by sharing your story with us, we send a migraine care kit or a headache care kit, I
Ooh.
should say. And since I know the person who sends those out, I could probably sneak a shirt in there for you.
Oh, that'd be great.
I'll
I could
my
wear it. I could wear it to work, and people will. Oh, Karen, maybe I'll wear the shirt whenever I have a headache. Oh,
There
let's
you
not
go.
talk to Karen too loudly today.
There you go. You
I
know,
love that.
the other thing to think about, and I didn't mention it with work, do you need work accommodations? So
Well,
the
yeah,
fluorescent
yeah.
lights can definitely increase
Yes.
migraine. You know, I've written work accommodations for patients. And also, again, putting the nightlight on your computer screen, and getting maybe tinted, like these are tinted glasses that I have for the computer to help reduce that blue light.
Yeah.
So there's definitely, and you know, asking people not to wear perfume, or heavy cologne, those types of things.
Yeah. Well, I work in a school with special needs children.
Oh, God love you.
So thank you. And the lights, so I'm under those fluorescent lights at school.
Yeah.
And I work with nonverbal kids who scream. So it's really a bad situation for me when I have a migraine.
Oh, yeah.
But I do love my job, so I've recently bought earplugs that this is a plug for loop earplugs. They're called loop, and they actually lower the decibel without muting what people are saying, so I could still hear what my coworkers are saying to me,
Okay.
but
Good.
it does decrease the sound.
Right.
Opposed to there's silicone as opposed to foam. The foam
Ah,
ones, you can't understand what people say when you have foam ones in.
right. Right. It's
So,
muffled. Well,
so
thank you for that
sure,
information.
sure.
That's a great tip. Well,
Katie, maybe we need to add those to the kit.
we have earplugs in there, but not that kind. So when we go to replenish, I think that is a great tip.
Mhm.
Yeah.
Yeah.
I have also heard of earrings that are like earplugs, so you can easily pop them in and
Oh,
out.
that's a great idea.
That's a
So
smart
they're
idea.
really accessible for people who are noise sensitive for, I mean, all different reasons. But for your case with working with kids, they may pull at something that's dangling. So
Yes, good point. Yeah,
yeah,
We
these
want
go
to,
really flush to your ear and you can't even see that they're in there.
yeah.
yeah,
Mhm.
yeah, absolutely. Well, if anyone has any additional questions, I feel like I always get the best questions the second after a Zoom or a meeting ends. Please feel free to take a picture or screenshot of my email address right there. I am happy to connect you with additional resources or even ask Dr. Williams any additional follow-up questions after the session ends. And I just wanted to personally thank all of you for taking the time to learn today. It can be a very isolating experience, and we're so glad that you took time out of your schedule to learn more today.
Well, thank you so much, Scotch Plains Library, for offering this. This was
Yeah.
wonderful. Thank you. And thank you, Katie, and thank you, Karen, so much. This was very informative.
Good, good, good. And thank you for taking care of our children.
Oh, my pleasure. I love it.
Good.
I
You're
think
in the
we'd all
right place.
to thank Dr. Williams and Katie for this fantastic presentation. It was so thorough, but also very clear and accessible. So we really are very grateful that you were able to offer this for us.
Yeah, absolutely. Thank you so much for having us. This is our entire mission of our organization is to help people. So we're really grateful to partner with wonderful organizations that bring people together.
Yep, yep. Thank you.
All right. Thank you so much.
Thank you all. Bye.
Bye.
Bye-bye.